Okay, I'll have the second one, please. Right, so I'm just going to show you a couple of cases just to follow on from what we've done and to show you how we treated both of them. Because we said you could crush the stent, you could snare it, you could deploy it where it is, or you could bullet with a balloon. So this was a case that, and this kind of takes you again to the vessel preparation and to stenting from distal to proximal. This was a 70, I won't bore you too much details, an 78 years old, previous bypass operation. They did not do a Lehman's vein graft to the diagonal and to circumflex, etc. But the guy was very symptomatic, normal LV, anterior ischemia. This was his LAD. You could see there's a lot of calcium in there. So I elected to go straight with rotablation. Wired the artery, did the rotablation. I think it was 175 or 1.5 to start with. And that went okay, and you think everything's okay, let's just go on. We pre-dilate the artery and put the stent in. And that's the left main stem in here. What I found out that because of the calcium, and maybe me being a little not as meticulous as I usually like to be, there was a small gap between the two stents. So now I have to deliver a stent through this left main stem to cover the gap. And that became quite really difficult because, again, physics and with the tortuosity and the friction, you could see the stent now has stripped off. And this is me seeing it coming off. I couldn't do anything when I was treated. You could see it on top of the left main stem here. I think everybody could see it in here. Of course, one way of overcoming this, if I knew, I thought this is going to just fly through. It's a 5-0 post-dilatation of the left main. You don't expect to have this problem, but I did. Sometimes what I've done with this, you could put a body wire, which deflects the stent from the opposite side, or sometimes you use a balloon. You don't have to inflate the balloon, just putting the shaft balloon inside that deflects everything you allow you to deliver. I didn't do it this case because I didn't expect it. And when I tried to bring the stent back, it came off. So of course here, what would people do? You've got a wire through the stent, and it was a 3.5, I think, stent. You could see the gap between the stent. What would people do? Would somebody crush it? Who would crush it in the left main? No one.
What is the size difference between the two stents?
This was a 3.5. The stent in the left main was a 4.5, but both dilated with a 5. So nobody would crush it in the left main. Who would snare it? One person. Who would deploy it in there, put a small balloon and deploy it in that area? Few. So what else? Try to retrieve it with the balloon. Okay. Well, that's absolutely valid. However, remember there are two fresh stents, and I think fresh stents are always problematic. To my mind, because they still haven't embedded, they still, even though you both dilated, they're still very fresh, nothing has happened. So if you try to retrieve that stent with the balloon, there's a big possibility because of the friction, you could easily affect the stent you deployed. I kind of thought about this and I said, okay, the best thing to do is just either deploy it. But given the left main was a 5 millimeter left main, I thought I'll just crush it. And this is exactly what I did. We took a balloon, crushed the stent, and you could see it right now, dilated with a 5.5 now. You could see the stent kind of against the wall, really, in that area. And we managed after this by putting a body wire and a balloon, a body balloon basically, to deliver a stent and cover the gap. But in this case, you could argue and say there's a lot of metal in the left main, but we used to do crush in the left main. We do kilot where you have two layers of stent. This was a thin strut stent, so I don't think it has made any difference. And with the 5.0 diameter, I think it's probably okay. This was a few years ago, and the patient's still absolutely fine, no issues. So all the methods we mentioned are valid. The only thing that stopped me from doing that is the freshness of the stent, and I thought that might cause a problem. But, you know. So that was any question in this case or comments?
Can I just, a process of thinking here, you know, you mentioned list of options, then you choose in the other one, but you've not tried. How come you choose? You know, we're talking about how we think and how we come and how anticipate in our mind without trying. You've not tried it. So how can you say it's going to happen that? I mean, I know it's just
I mean, I didn't
it's
try
a philosophical question, but I
Yeah.
think it's important.
I mean, one option would have been to deploy it, put the big stent and go, because again, the stent currently, you could, any of them, 3.5 could go to 5, the majority of the stent, it could go to higher pressure. My thought was, because I didn't want to jail the circumflex with 2 stents. It's still not a major problem, but this is what I thought, and I thought if I crush it on the side, I couldn't move it anywhere, why do we do it? Sometimes, I can't justify it at this time. Why at that time I thought this is probably the easiest option. But certainly I did not think retrieving it with a balloon was an option to me at that time.
Dr. Abdulrahman.
So I have another thought. I just want to see what you think of it. So taking another balloon, across to that smaller balloon than whatever you can get across it, and then actually bring a guideliner and trying to bring it a little bit and the guideliner over it. Have you ever tried something like this?
You mean to trap it and bring it back?
So you just basically stabilize it when you bring a guideliner over it. So you get the guideliner to basically engulf it while you're pulling back. So the difference in the guideliners is sometimes allow you to bring it inside rather than it to be crushed. But it could get basically accordion like when it comes over the guidelines. But have you ever tried to use a guideliner to facilitate retrieval of such a thing?
I have, and I did not like it, because exactly what happened, you have no control how it's going to work, particularly in a tortuous artery. And we ended up, instead of the stent being normal length and kind of nice, it became all crumbled. So when you come to crush it, it just became a lump of metal. Yes, it is only 80 micron, it's not a big deal, but this is why I did not try it. But it's a very kind of intuitively very nice way to do it. But I don't think you could execute it all the time correctly. So you have no control whether it's going to crush or going to come into the guideliner.
Dr. Mohanad, do you have another case?
Yes.
Okay, after the next case, we'll have
So
more
quickly,
questions. Go ahead, Dr. Mohanad.
So this is another case, not one of mine. This is one of my colleagues who was doing it, but I was involved to be asked what to do and how to do this. This was a primary angioplasty, so comes in, or I think, no, sorry, SES, but late presenting acute MI. Anyway, this is the angiogram for right coronary arteries. It was changed to an AR guiding catheter, 6 French, wire goes in. You can see the thrombus. And they tried to deliver a stent. They delivered a stent in mid-course, but now there's a second stent needs to go in the proximal part. How the first one went, and that often happens. You find the first stent goes, and whether you lift a flap or change the anatomy, whatever it is, or also sometimes when you deploy a stent in one area, when you come with the second stent, they kind of get to each other on this side, so you can't deliver it. So they took a guideliner. Despite the guideliner, the stent would not go. They tried to deliver, the stent wouldn't go, so they decided to retrieve it. This was taken out without fluoroscopy. The same as we're not going, let's take it out and do something. Anyway, the balloon comes out, there's nothing on the balloon. Where's the stent? So there you go. So the stent now is in the aortic cusp, sitting in the sinus. So what do we do now? Any volunteers? How will you snare it in the aorta? There's no wire, it's sitting in the aorta. You can't snare it. This is a very difficult. This is maybe you could try with the myotome, but again, this is the danger of damaging the aortic valve and damaging the aorta are not small. Anyway, the operator at this stage, I still wasn't there. They decided to carry on with the PCI, which is fair enough. So they go and stent the artery, prepare it more and stent it, and now the stent is there. I think the operator decided to see if the guide catheter could move the stent somewhere, or whether it's by mistake, I don't know. So this is happening. They take the wire out and they do it, and now all of a sudden the stent is gone. So what do you exactly? Where? So we said, I mean, I haven't seen, it's a long stent, so the chances of this going into the cerebral circulation are very little. Even small stent, as I said, because of the rheology and the flow. So of course now everybody's wanting to see where the stent is, and you start screening and moving the table everywhere. That's what happened. So you could see starting to go and find where is the stent. Of course it's gone from the aorta. Now you could see it down here now in the renal artery. So now, I mean, I probably said that before, gave the the game away. But what would you do now? Would you leave it in there? Who would leave it? Okay. Yeah. So you could crush it. I mean, oh, sorry, go back. Just leave that for a second, please.
Give
Thank
him
you.
2 minutes, please.
Yeah. So, of course, now, this is, if you leave it, there's a higher risk of thrombosis here because it's kind of, you know, it's not against the wall. To crush it, you're going to be stenting. This is a big artery, at least 8-10 millimeters. So you need a peripheral stent, which is fine. You could get it from peripheral or in radiology. In this case, we decided to go and snare it. So we go femoral, take a JR4. By hook and a crook, the wire went through the stent. Not through the middle lesion, it went through the stent and outside, which is really, really good. And you could see that just by the balloon itself, even without the snare, started moving. So we pulled it out, came to the femoral artery, and it was all. I don't have the fluoro when they came out. It came out from the sheath. Because what we did also, this is important when you're doing this, you have to make sure that the sheath is a little bit bigger than the guiding catheter. Otherwise, you could get stuck and the stent could go over there. So we had an 8 French sheath, and this is a 6 French catheter, and we managed to retrieve it out and came out. It was luck because it was bent, the wire went through one side and out, so kind of trapped the stent very well. But even if it didn't, a snare would have been much easier to collect this. But yeah, these are the cases where you think, okay, you saw it delivered distally and then proximally there's a problem. And anyway, the patient did well. We didn't have to crush it. We didn't have to put a stent in the renal. So multiple way of dealing with this, and I think the outcome was very good. And that's all what I have.